Okay. Good morning, everybody. It's a great pleasure and honor for us to be here to give you a joint grand rounds with Professor Jan Boublik, Marianne, Chen, and myself about point-of-care ultrasound in anesthesia and perioperative medicine. Where are we and where do we go? First of all, I have to apologize for Marianne Chen. She cannot be here with us. So we will present her slides and do our best to present her as good as possible. What are our objectives during this grand round? First of all, we want actually to discuss the definition of focus. What do we mean with point-of-care ultrasound? We want also to give some examples and important applications of point-of-care ultrasound in our practice in anesthesia and perioperative medicine. We will also discuss some point on how point-of-care ultrasound is associated with and may affect outcomes. And then we will also give you a summary about the training opportunities in our department to learn point-of-care ultrasound, and also how our residents are now trained and what our resident focus curriculum looks like. Jan will also has worked a lot and will give us a summary on in general point-of-care ultrasound at Stanford Healthcare, and also talk about the billing opportunities of point-of-care ultrasound. And then at the end, we would like to conclude with discussing opportunities and challenges in the future of focus, and in particular also in our department, how we can proceed. Yeah, none of us has any financial conflict of interest to declare. And we would like to start with a case. As you know, I'm working a lot on labor and delivery, so I would like to present a case that occurred to me a few weeks ago, where we were taking care of a 32-year-old lady. She was T2P1 at 38 weeks, and she was a very healthy young lady. She was in spontaneous labor. She called us for an epidural, and she had a well-working epidural. And the fetus was delivered, and then the phone ringed and said, Dr. Orton, can you please come to LDR9? So I came to LDR9, and that's what I saw, an everted uterus. So we gave nitroglycerin to hope that it relaxes and the obstetricians to invert it. But unfortunately, the obstetricians were not able to invert the uterus. So we transferred this patient to the operating room. In the operating room, the first thing we connected to monitors, heart rate, she was tachycardic, blood pressure, lowish, EKG and sinus tachycardia, and her saturation was in 99%. And I converted to a GA. After the GA, the obstetricians were able to invert uterus, but then we had no idea what the EBL was. Because, I mean, we were in the room, we were transferring the patient, we were in the OR, it was very busy. So I said, okay, let's put a cardiac probe on the chest. And that's what we saw. So you see on the first image, a parasternal short axis view with the left ventricle very hyperdynamic, small. The parasternal long axis view, you see it's not a very good view, but that's very typical for a patient hypovolemia. When the ventricles are so small, it's difficult to get a nice long axis view. And also here on the right side, you see a completely collapsed IVC. Okay, so during the case, we called for the massive transfusion protocol. We fluid resuscitated this patient. She received high volumes of crystalloids, colloids, blood products, and also hemodynamics significantly improved, but her saturation was suddenly 93%. So again, we checked, and you see this looked very different. It was also much easier actually to get the images. The LV was well filled. Still, image acquisition was not so easy, but also you see the IVC now, you can clearly see it. But why was she desaturating? So we put also the probe on the chest to check actually for the lung ultrasound. And what you see here, a lung ultrasound image from the right upper quadrant, in the right lower quadrant, in the left upper quadrant, and in the left lower quadrant. And you see always these more than 3 B lines. And if these B lines popping up, if more than 3 or more B lines in more than two quadrants on each side, that indicates that you have an interstitial pulmonary syndrome, indicating that you have an increase in extravascular lung water. And in a patient that has normal cardiac function, normal vascular permeability, this always indicates hypovolemia. So the consequence, which was very difficult for us, we stopped all fluids. The point I want to make here is also the important combination of cardiac ultrasound with lung ultrasound. Taking this information together actually gives us more information. So what did we do here? We did a so-called focused cardiac ultrasound. And the focused cardiac ultrasound is the terminology as recommended by the American Society of Echocardiography, as well as the European Society of Echocardiography. And we always, when we talk about focused cardiac ultrasound, we must remind us one thing. We are not cardiologists, and we will never be, I think most of us will never be cardiologists. Yeah? So the scope of a focused cardiac ultrasound is very different. And in the end, we only want to answer 3 questions when we do a focused cardiac ultrasound. That's why is this patient hypotensive? Might this patient benefit from fluid loading, or is major LV dysfunction responsible for this shock state? And this is just an example. When you put the probe on the patient's chest, the image can be so diverse and immediately direct you to a completely opposite direction. Here on the first image, a parasternal short axis view, which shows you LV failure, which looks completely different than on the second image, where the patient is hypovolemic, or on the third image, where the patient has significant pericardial effusion. Now here, image 5, where you see the right heart strain with a fulminant PE, or on the 6th image, a patient with vasoplegia. And the treatment is very diverse. So just one look on the chest can really immediately direct you to very different diagnostics and also therapeutic solutions. Yes, obviously the focused cardiac ultrasound, per definition, you do it at the bedside at the point of care, and it's repeatable, and it's a targeted diagnostic test. So with a focused cardiac ultrasound, you don't measure a lot. In order to answer these 3 questions, you need to be able to answer with yes or not, per definition, these 6 diagnostic targets. So we have to be able to identify, is systolic function of the LV or right ventricle or RV normal or abnormal? Yes or no? Are the cardiac dimensions normal or abnormal? Is the volume status normal or abnormal? Is there pericardial effusion? Yes or no? Are there any gross signs of chronic cardiac disease? Yes or no? Or are there any gross signs of valvular disease? It's not up to us to grade this valvular disease. We want to identify it to know, do we need a consultation from the cardiologist or not? And also many studies have shown that after very defined but feasible training, that novices and non-cardiologists can diagnose hypotension secondary to this reason. So to systolic dysfunction, significant hypovolemia, RV failure, pericardial effusion, gross valvular pathology, or LVH, with a very, very high level of agreement to a level 2 and level 3 specialist. So also in our scope of practice, it's really feasible to do this focused cardiac ultrasound. Okay, I gave you now a very clinical definition of focused cardiac ultrasound, but POCUS is much, much more. And so Jan will give you the definition of the more technical approach of point of care ultrasound.
Okay. So I'm not going to belabor point of care ultrasound and how it's important, and less so because Dr. Order made an excellent point in terms of how the distinction between focus and comprehensive TT, it's more sort of like it means different things across different specialties. So it's something to be mindful, as this is a skill that's not limited just to anesthesiologists, but other specialties use this as well. So if you look at different specialties and sort of definitions, you see different aspects that jump out at you potentially. But what we do see through this is that it is something separate that requires additional training for this skill. There is a distinction that gets acknowledged from comprehensive exams, and also that it's something that is potentially billable. So, and then just as, you know, focus to focus, not all focus is the same, right? So there is procedural versus diagnostic, and, you know, we all practice a lot of procedural and some of us diagnostic point of care ultrasound. There's different levels of complexity and risk, which is going to come into what at the adult hospital level, because the program I'm talking about is related to the adult hospital. There is different complexities that then require different amounts of training and ongoing competencies. And some parts are not defined by, as even though they're very much ultrasound at the point of care, are excluded from the point of care ultrasound per se, because the dedicated programs such as our intraoperative TEEs by our cardiac anesthesiologists. And then there's always a local definition, just like all politics is local, you know, there's always and so there's an ongoing discussion on whether focus is defined as focus as, you know, part of the physical exam. So here is an ongoing evolving definition at Stanford Healthcare at the adult hospital, as I said. And so what jumps out at me is that the physical exam is not defined as focus because it's not considered to be a billable entity, because it's limited at this, and it says medicine here, to confirm physical findings. Also, the other thing that jumps out at me here is that a dedicated structured program in this version, the intraoperative TE has left the dimension down there, and it's limited to radiology and cardiology. But there's something to bear in mind that we are very much involved at the diagnostic and procedural use. So not just because the AMA president-elect was here last week, but the biggest house of medicine, what does the AMA have for opinion? So there is a document on the privileging, and what we see is that, you know, it's very much in the scope. It acknowledged a broad use, and it is very much, you know, within our specialty and our department that we can control what our definition of our involvement with focus is. So this is the newest potential credentialing language that has been put forward by, and the thing I underlined is that, you know, the department is responsible and, you know, for review and approval of the use of scope and criteria granting. Now, I'll be remiss, particularly with Dr. Pearl in the audience, to not mention the difference between credentials, credentialing, and privileges, which is a whole different lecture. So the credentials is obviously what qualifies us. The credentialing is to verification of this, and the privileges are granted by the hospital. Now, in our case, it's the same entity. Some hospital and healthcare systems have separate entities for this. But this evolution also, most importantly, gives us the opportunity of being able to control, to a certain extent, our involvement here. So with that, we'll jump back to Dr. Ortner.
Yes, I think an important question that also always comes up is, okay, we know that focus, it's interesting and nice, but actually, does it change outcome, or how does it change outcome in our practice? And I just want to give you here a brief overview. In the settings of out of the hospital emergency medicine, on the intensive care units, in rounds, but also in anesthesia, it has been shown largely that the use of point of care ultrasound expedites the diagnostics, and also the diagnostic accuracy. It also expedites the initiation of treatment. And in particular, in perioperative medicine, in anesthesiology, also on the pre-op clinic, it has been shown that it changes medical management. On the intensive care unit, it has been shown to decrease the length of stay. And there are also first good indications that it may affect and decrease mortality in certain patient populations. I want just to give one study that has been published by a group that is also very, very active in the point of care ultrasound in anesthesia in Melbourne. And they studied the use of cardiac ultrasound on the pre-op clinic. And they were presenting a study where they have studied 100 patients that were older than 65 years and had suspected cardiac disease. And they showed that with using focused cardiac ultrasound on the pre-op clinic, they changed the anesthesia plan in 54 out of 100 patients. They said in 20 patients, this led to a step-up care or a step-up in treatment, including some, it showed that these patients needed to be referred to cardiology. It also showed them the indication that these patients will need invasive monitoring. And they also that these patients will need to have booked a high dependency unit, so an intensive care unit after the procedure. But I think what is even more important that in many cases, in 34 patients out of these 100, it actually led to a step down in treatment, including that they did not need to cancel the procedure based on the results that they have to cardiac ultrasound. They did not need to refer these patients to the cardiology service. And they did not need to use invasive monitoring. And also the same group have published a retrospective study, but also prospective studies in applying focused cardiac ultrasound in the pre-op clinic for patients undergoing hip fracture surgery. And they showed, even if the data has been discussed, but that there has been a significant association of lower mortality in those patients where on the pre-op clinic the FCU has been performed. Okay, what's of course a major point in point of care ultrasound is how do we train our people? This here, and we all know that training for echocardiography, there are so many different pathways out there. There are so many different certificates, but what they all have in common is they all have a minimum requirement of 10-hour lectures and also of workshops where you do image-based training. Also, all these different certificate pathways and certifications require a minimal number of scans that you do under direct supervision. Where there's so you can never give an absolute number because every trainee is different. But in general, people need 20, 30 to 40 echocardiographies under direct supervision. Then what is also an important part in all these certificate programs is the training of image interpretation. And then also depending on the expertise in all the certificate programs, you require to collect a log, depending, ranging from 50 to 300 cases. And also all these pathways conclude with an exam. What we have now since last year, in anesthesiology, the American Society of Anesthesiology introduced the so-called diagnostic POCO certificate program. And when you see this POCO certificate program launched by the ASA exactly includes all these points that I have shown in the previous slide. So it starts with a QI improvement plan that you have to submit. You have to provide evidence of POCO's education and training. So with including theoretical training and undergoing a workshop. It also includes that you need to interpret online studies. So the ASA here provides a significant number of cases using cardiac ultrasound, lung ultrasound, gastric ultrasound, and fast ultrasound that you have to review. You also have to carry a log and collect a number of scans. So the ASA requires for the certificate 50 TTEs that you have to personally do 30 lung, 30 gastric, 30 fast ultrasounds. Only a smaller part have to be directly supervised, and you have to take at the end an exam. All this theoretical part of the POCUS certificate give you 40 AMA credits, but also what maybe the main point is here, in order to cover the theoretical parts of the ASA POCUS certificate, what the ASA says, it takes you 40 hours plus collecting your scans. So also in our department, many faculty have signed up for the ASA POCUS certificate. 92 colleagues have signed up. 65 were in 2021, 27 in 2022. So far, 6 have completed it. But I think we have one more year to complete the program. Also, all our residents that start the residency program in our department are offered to participate and work on the ASA POCUS certificate program. We have so far in our department 4 local mentors that help faculty to give them support and also review the scans. That's Jan, that's Marianne, that's myself and Ban Sui. And also we, as you know, we have a POCUS faculty that do POCUS training on Tuesdays and Thursdays, and the minimum requirement in order to join the POCUS faculty is our ASA POCUS certificate. And also, what have we done to support our faculty in POCUS training? So we have started 2 or 3 years ago to provide workshops on focused cardiac ultrasound, and so far 140 of our faculty have undergone this training. Also, our faculty have the opportunity to train image acquisition when they sign up to scan together with POCUS faculty on Tuesdays or on Thursdays. Also, as I've mentioned, the local mentors are here to also review scans and to go through the leg book. And also on Box, if you we have this link where there's a lot of educational resources for colleagues that are interested in deepening their knowledge in point-of-care ultrasound. This is our resident curriculum, and I want to thank, also to take this as an opportunity to thank Marianne Chen, who has worked really and put a lot of effort into putting a structured point-of-care ultrasound program to our residents. And we have to be aware that there are not so many residency programs that have such a structured program. And what Marianne also wants to point out with this slide is we try not to just offer 1 or 2 workshops over the residency programs. We really try to provide a continuous training so that our residents have continuous exposure to use of point-of-care ultrasound. We start in the first year where our residents come with very different background, with hands-on workshops. Over the first year, they have also 4 CA lectures where POCUS content is covered, and we also offer small workshops where residents can practice the image acquisition. And what is also important, on Tuesdays and Thursdays, when our residents are on the periop rotation, they have protected time for 2 hours where they learn with POCUS faculty the image acquisition. Then in the second year, the idea is that the residents scan during their subspecialty rotation. So when they're on the ICU, when they're on cardiac, when they're on regional, when they're on labor and delivery, when they're on the PEC rotation, so that they get exposure. And in the third year, that those that are interested get more support in order to to complete the ASA POCUS certificate program. And one important part also in the OSCE training as a CA3 is that they also get advanced taught in advanced topic of point of care ultrasound. And we also have created a lot of education material that interested residents can use. The goal actually is that every resident at the end of the residency program has the skills to use POCUS in their future clinical practice. And if they are interested, that they can complete the residency with the ASA POCUS certificate. Yes. And also we have invested a lot of energy actually in the education of our fellows joining our department. And why? Because the American Board of Anesthesiology has now included point of care ultrasound as an exam requirement. So since 2022, trainees or the exams also covers cardiac ultrasound, and the trainees have to show that they're able to do image acquisition and to interpret the image. With this year, they also include pulmonary ultrasound, and in 2024, they will also be tested on gastric ultrasound. And so that some of our fellows that join us have not done this during residency. So we have also included now offered in many fellowship programs, 1.5-day POCUS workshops. And also last year, for the first time, we did an OSCE exam preparation workshop for fellows that are not exposed to point of care ultrasound, for example. And so in order to also prepare our fellows for the AABA board exams that now require point of care ultrasound. Okay, I hand off to Jan again to give us information about POCUS and Stanford.
This is the POCUS program at Stanford as it's currently created. This has been a journey I'm going to allude to, and it's with the foundation of the governance committee, then the program team, and management to cover all the different aspects that need to be covered in this house or pantheon of POCUS, with the absolute idea being improving patient safety, and also as it's important to keep the lights on compliance. So the guiding principles where it's absolutely right, it comes from a place of there's a lot of POCUS being done, but it's hard to find. And so increased transparency so you can access, because as Dr. Ortner showed, one of the big values of POCUS is to be allowed to have serial exams and compare changes, and also see if, and have these documented. So standardization to a certain extent and increased revenue is something that's always appreciated, but it's those first two items that, transparency and access really to improve patient care, safety, and that have been the driving forces behind this. So use assumption, right? So this is what the program, so as the foundations of participation has. So you have to participate in the governance committee, and also departments are expected to use point of care ultrasound to develop training, proficiencies, and credentialing based on national guidelines. And there's acknowledgement some level of additional training is needed. I don't necessarily 100% agree that it's in addition, or even if it's included in the specialty certification, but the important part is that the department determines minimum requirements in aspects of QI, QC, and proficiency and credentialing. So there's a whole lot going on in this slide, but just to iterate that a whole lot, there's been a journey. It's been, in addition to the pandemic, an evolution within the program, starting in 2019 with a task force and formalizing into a program 2020, and then re-engaging up to on the right side of the slide where tomorrow, so we couldn't be more timely with these grant rounds, the ED is going to go live. And there have been a lot of learnings, a lot of items that were thought to be a quick fix by the program initially that had to be addressed, such as IT builds and verifying CP orders, equipments, and a whole lot of other things that weren't necessarily made easier by the pandemic. So the program team and what comes out with that is sort of as a sort of a point of contact both for the leadership of the institution as well as all the different sort of like stakeholders and partners that we need to have in terms of making this work within EPIC and the institution. So although it is pretty small font, and on the left you have the program leadership that's headed by David Larson from radiology, and as well as the medical directors, Birta Lobo from the ED and Lou Chen from radiology. But what we do see is that our department in their various passions and subspecialties is highly involved, and that we are certainly at the table. As you know, just like with the education, although it's like this, we're very much on the forefront of focused education nationally. So they do have a website where a lot of these things and additional things are present, including the equipment menu that's not exclusive and not limited to these machines, but this is just something that you can see which ones are supported within EPIC. And also cleanliness next to godliness, also little details such as folks' equipment cleaning, that is in accordance recommendation with the American Institute of Ultrasound and Medicine. So billing. We're not going to, in the interest of time, put you to sleep with this, but while as a caution, this young artist, nobody wants more problems. So can we get reimbursed for POCA studies? And also not to get political, but yes, we can. So what do we need to do? All these 5 items need to be completed in order to be built, and that gets also checked by revenue integrity and compliance on the back end. So images are saved and retrievable. It seems like a basic thing. As it turns out, it is not that easy. A lot of these items are already included in our protocols, but the institution has gone with although it's concerning always from a CME standpoint that there is a particular company use, but it's as a what's called an interface, and to get into EPIC, a VNA, that they've gone with one company, and there is templates that we can then modify to our need, but that is what they went for the ED pilot. So luckily, in the terms of image labeling, sort of like common sense has, or just uncommon, has prevailed, and there are some basic requirements to be able to link the studies, but even items such as annotation of anatomical structures are optional, because the reality is that in clinical practice, outside of radiology, we probably don't annotate structures as much as we should. So this is how it's going to look, and just briefly in the ED pilot, the documentation there, with the different items as delineated previously, and an attestation, and on the right is a screenshot in EPIC. So potential diagnostic CPT codes, they are there. This is sort of an excerpt, not accounting for other items such as maintenance of certification, technical fees. that come directly from a matrix that was generated by the program and revenue integrity. So the codes are there, but we need to fulfill the other requirements to be able to, actually use them. So
one more case.
Just to not put you completely to sleep, one more case.
Yes, is she here? No, a resident. No, it was with Bucha. I was working together with her a few weeks ago, and she called me, "Hi, Dr. Ortner, we have a short cone biopsy case tomorrow." And so we reviewed the chart. It was a 43-year-old lady, 170 centimeters, 104 kilos BMI, so a little bit obese. She also had a history of A2 GDM, not very well controlled. The HbA1c was 10.5. Also history of PCOS, and her meds, she was on glipizide and on metformin. And the question was, what shall we do for her airway? Shall we do a MAC? Shall we do an LMA? Shall we intubate? And I said, okay, let's wait. Let's actually see the patient first. So we saw the patient in the pre-op at 6:40, 6:45. Good airway. She's NPO since 8 p.m. last night. She was very nervous, anxious, and the nurse told us her glucose is 270 milligrams per deciliter. So I said, why 270? I said, Puja, let's do a gastric ultrasound. And we got the ultrasound, and it took Puja 2 seconds, really 2 seconds to get this image. So you see here completely full stomach. For an elective case, short case for cone biopsy, how would you proceed? Would you cancel the case? Would you do a spinal? Would you wait? Tell the surgeon how long? So we did a rapid sequence induction. Just a few points on the utility of point-of-care ultrasound, gastric ultrasound. When do we do gastric ultrasound? It's a risk assessment, but it's to assess if a patient is at risk for pulmonary aspiration. That's what it is. It's not important to say if the stomach is full, empty. We want to know, is this patient at risk for pulmonary aspiration, and to adjust our anesthesia management for that. Because we should not forget, if here our fasting guidelines by the ASA, they are defined for healthy patients and for elective procedures. But they are not defined for example, women in labor, but also for patients with coexistent diseases. I think many of the patients that undergo elective procedures have diseases, diabetes, renal liver dysfunction, neurologic diseases. And these ASA NPO guidelines are also not applied to conditions affecting gastric emptying, which are many different medications, or if a patient undergoes an urgent emergent procedure. So what can we do with gastric ultrasound? We can do a qualitative assessment to see, is this stomach empty, is there clear fluid, or is there solid liquid? And we can also do a quantitative assessment, how much clear liquid. And what are potential indications for gastric ultrasound? It's if there is conflicting information regarding the last meal, and I think we observe this situation on a regular basis, but also for patients with severe comorbidities, like our patient with diabetes, or patient with end-stage renal disease, liver dysfunction, or patients undergoing urgent and emergent procedures. So if you are in the situation and you're working on the MSD, and you think, I need help, and I would like to call someone to do a point-of-care ultrasound, what would be indications for you to call for help? If, for example, you have an hypotensive patient in the PECU, or if you see your patient in the pre-op and there's no pre-op echo, but you are concerned about worsening symptoms in these patients. Also for patients that are unstable in the operating room without a clear etiology. And also if you want to assess your patient for risk of pulmonary aspiration risk. And who can you call? This still is a thing in progress, but in general, if it's, you can call a POCUS attending on Tuesdays and Thursdays from 10 a.m. to 3 p.m. But also you can actually reach out to our peri-op attendings. They're very busy, but if they have time, They are all trained in TTE, and they can also help out if you need to perform a focused cardiac ultrasound. Also, many PECU residents, in particular if they're later on the training, they can help you. And of course, we also have the TE attendings that can help you during emergencies. Yes, Jan.
All right. Yeah, so, and just to come back, even though Dr. Ortner really stole a little bit of the thunder. So, right, there's plenty of opportunities and there's potentially some challenge for the future of life in general, as well as for POCUS at Stanford and within our department. So, starting in the fall, there's going to be a Stanford Regional Anesthesia POCUS pilot that was, this is again from the website that I alluded to. And this was supposed to start 2 years ago, but just as it was supposed to take 4 to 6 months to complete the first pilot in the ED, things took a little bit longer in some aspects of life in the past couple of years. So why regional? Anybody who has done any prioritization work, this is like an impact prioritization matrix. And although it doesn't say regional anesthesia, it says anesthesia, which is partially due to the confusion by the program manager that regional anesthesia and anesthesia aren't the same. But why regional, right? Not only is it a more controlled environment than the operating room, where workflows and more importantly glitches can be tried in a more safe area. It covers procedural point of care ultrasound with image storage being addressed, and as well as peripheral IVs translate one-to-one to central lines and arterial lines. But also as a little gateway into diagnostic focus with a lung ultrasound for some of the chest wall procedures at the very least. It also covers in the implementation a lot of the areas that the hospital cares about. The only reason that the revenue potential is a neutral is that as of this calendar year, unfortunately, ultrasound has included a lot of the CPT codes for nerve blocks. So the revenue potential is a lot smaller than it used to be. So just sort of as a visual, this is where we are, and on how within the program, the timeline gets shifted, and acknowledging that now the program has shifted from going to small wins in small areas. So as this timeline will show you here, you can see that during the summer, small outpatient areas such as neurology and rheumatology are going to start with their pilots, while the summer is not the best time for us to be starting our prep for the pilot. So what is involved? So there's a whole lot of stuff, as you can see, which is being addressed now or has been already addressed. And it doesn't stop, right? So there's a lot of 10 items that need to be completed. So the hope is, or the goal is, that focus users should be trained. They don't have to be. And there's flexibility in terms of grandfathering and what is going to be included. And but there's work to do. And with that, Dr. Ortner would like to discuss the current state of focus in our department, so to speak, and a proposed structure. Obviously, with Dr. Chen, who is not here today because she's concurrently giving grand rounds in Arizona. So even Marianne Chen can't be in two places at once. But there is a need to, because of her new added responsibilities, to find a new person who's going to spearhead the educational efforts. And this is the structure that Dr. Ortner, one of the potential structures that is very much open to discussion, that we are thinking of to also to formalize sort of like, or to what has been covered by all of us concurrently and as a joint to formalize and have clear roles and responsibilities. Dr. So we do have some departmental support here and also hospital support for the QI/QA as part of the POCUS pilot. Yeah, but I mean the question to be answered is like, do we want to have a POCUS service, and how is it going to look like? Is there some departments nationally and internationally are starting POCUS fellowships? I think we very much have the expertise and the resource to do so. How exactly it's going to look, there's varying models that are currently being applied. And also the question is, do all or enough faculty have enough the skills to use POCUS in their practice, that we can use this both clinically for our patients as well as to educate our residents?
Yes. Thank you. Are there any questions or points that you would like to discuss?
Lots of questions.
No, excellent question. And
it's on microphone.
And I wholeheartedly agree. As for the first part, that is an ongoing concern that I've raised with the program, that while that may work for more planned studies, that it in all likelihood will not work for, reliably if that what the program is after for anesthesiology. More so in regional anesthesia, right, where we've requested blocks, we had them. So that's, but thinking of the department, I have discussed it in my proposal that I will continue to advocate for, is to have conditional orders when they get booked for the interventional platform, for example, just to cover the majority of, whether with the case or the admission orders, that an ultrasound order, they don't want a generalized order. So the devil's always in the details, as you know, so it might have to be customizable. So for cardiac, it would be vascular access, and for central lines. So as for the second part, because of financial compensation, it's, we need to keep the lights on. And it's also, from a compliance standpoint, underbilling is also potentially a liability. As Dr. Pearl can attest to it, we've had that discussion about 2 years ago, and while there is a financial benefit of at least 6 figures that we calculated in our back of the envelope discussion, we're just with vascular access alone, it will have to be executed. And your first question, and having it automatically in there, is going to facilitate that greatly, I think.
Yes, please.
Well, in the education setting, of course, in the clinical setting, with it being a different entity, LPCH, that is not included in this, as unfortunately it's for the peds, an adult-centric program, that there is communication with LPCH and some of the IT leadership, but for the clinic, but not that we can take the lessons and apply them to LPCH.
So I think my feeling was they first want to try and see that it works at Stanford Healthcare, and then it will go to LPCH. And I think also together with the team of pediatric anesthesia, we have worked a lot on training. We have also on EPIC, actually, I think we are even ahead on EPIC at LPCH concerning our POCUS procedures. So it seems that LPCH will follow. And we are constantly also with N1, I'm also working with IT, that we don't fall behind. Yeah. So once we see that it's live and working, which takes a while at Stanford, that actually LPCH can adapt it very quickly. So, and I also want to thank actually the group of PEDS Anesthesia, because I felt that there's a huge motivation there of people learning and applying point of care ultrasound, diagnostic and procedural. Any other questions or comments? Do we see, is there any online question or comment? I don't see that. Do we? Okay. Then thank you for bearing with us for this grand rounds, and happy Monday.